Good afternoon, everyone. My name is Autumn. I am a member of the outreach team at SunCloud Health. Thank you for joining us for our National Collaborative Learning Series and today's presentation, First Do No Harm. At SunCloud Health, we provide a full continuum of behavioral healthcare services for both adults and adolescents, including residential, PHP, and IOP. Our approach is highly individualized, combining evidence-based treatment with integrative care to meet each patient's unique needs. We specialize in the treatment of complex co-occurring conditions, including substance use disorders, eating disorders, mood disorders, trauma, and other mental health challenges. Our multidisciplinary team is dedicated to helping individuals achieve lasting recovery and improved well-being. SunCloud Health proudly serves patients in the Chicagoland area, with locations in Northbrook, Lincoln Park, Naperville, and Matson. If you would like to receive additional information about SunCloud Health, please feel free to send me a message, or you can put your contact information in the chat and we will connect you with someone on our outreach team. Before we begin, we have just a few housekeeping items. This session is being recorded for educational purposes and will be available on our website for later viewing and sharing with others that couldn't attend today. We encourage your participation and welcome your questions throughout the presentation using the chat feature. For those of you attending for our continuing education credit, you will receive an email following today's presentation that includes both a quiz and a survey. Please complete these requirements to receive your CE certificate. Your CE certificate will be emailed to you, and you should expect to receive it within 7 days of submitting the required materials. The follow-up email will also include a link to leave a Google review if you've had a positive experience with SunCloud Health's continuing education programs. We are currently sharing links to register for our upcoming CE events. We encourage you to take advantage of these continuing education opportunities and join us for future learning sessions. If we are unable to address all questions during today's session, a member of our team will be happy to follow up with you afterwards. Now it is my pleasure to introduce today's presenter. Dr. Elizabeth Sita is a board-certified psychiatrist specializing in the care of patients with eating disorders. She completed her undergraduate training at the University of Chicago and graduated with highest honors. She then earned her medical degree at Northwestern University's Feinberg School of Medicine and was recognized with the Chairman's Award for Excellence in Psychiatry. She subsequently completed residency with the Department of Psychiatry and Behavioral Health Services at McGaw Medical Center of Northwestern University, in which she was elected chief resident and received the Resident Psychiatrist Leadership and Service Award. Upon completing her training, Dr. Sita came to Ascension Alexian Brothers Behavioral Health Hospital, where she served as the assistant medical director for the Center of Eating Disorders and the director of transcranial magnetic stimulation services, before transitioning to lead the new inpatient eating disorder unit as medical director of eating disorder services at Ascension St. Joseph Hospital in Chicago. In these roles, she cared for a multitude of adolescents and adults struggling with anorexia, bulimia, binge eating disorder, and other eating disorders, as well as severe co-occurring mood, trauma, personality, and substance use disorders. Dr. Sita has been recognized throughout her training and practice for a commitment to excellence in patient care and for her ability to engage patients in their most challenging moments. Her passions include the care of treatment-resistant eating and mood disorders, as well as questions of medical capacity and end-of-life decision-making. She believes that first and foremost, human connection is key to mental health and well-being, and strives to share this philosophy with each and every patient encounter. So without further ado, here's First Do No Harm with Dr. Elizabeth Sita.
Thank you, Autumn. Thank you everyone for joining. I think we got to update that bio because I am at SunCloud now as the medical director of adult services, and it has really been a wonderful opportunity to continue to grow and learn. I had an opportunity to work with SunCloud over the years in my other roles and really just appreciated the nuance with which they approached patient care, and that's part of what led me here. And it has been as expected. And thank you all for joining in today. So I want to start by saying, I think this is a conversation that would honestly best be had in person. It is not meant to be dogmatic. It is meant to be iterative and conversational, because this is not necessarily something that I have all the answers to, nor do I believe that anyone has all of the answers to how we go about having these complicated conversations. But I think it's important that we continue to think and refine our approaches and kind of lean in on one another about what's worked and what hasn't, rather than burying our head in the sand and saying, nope, we can't have these conversations at all, which I don't think serves anyone. So while we're virtual, I would just say feel free if you have questions, if you want to pause at a specific location as we're going through the presentation. I have no issues with that at all. I've asked Autumn just to interrupt me as questions pop up. So as interactive as we can possibly make it, because again, this is meant to be a space more for thoughtful dialogue and talking through how we best approach this specific conversation. That is, how do we talk about health and wellness and body in clinical settings? Next slide, please. So I have nothing to disclose. Learning objectives for today, we want to talk about weight stigma in healthcare. We want to have a dialogue around how to use patient-centered, non-stigmatizing language, and we want to talk about how to integrate risk assessment with eating disorder informed care, which is actually quite challenging. And I can tell you the impetus for this specific presentation was I have a friend and a colleague who is a pediatrician, and she attended a similar talk at an academic institution and left, as she shared with me, feeling even more confused because her takeaway, this was like an adolescent medicine conversation, the takeaway was you can't have these dialogues with patients. You can't talk about body, you can't talk about size in a safe way. And so it's best just not to do it. And I think she left feeling very defeated and uncertain. And to me, that's not acceptable. I mean, we have to have the space to have hard conversations with people. That's really, as a psychiatrist, what I do, bread and butter, day in and day out. And we also need to be able to hold nuance. I think so often the pendulum swings to one extreme or the other, and the gray is lost. And so that's really, that doesn't serve anyone. So that's kind of the idea here is let's talk about, is there a way to have this conversation? What is it going to look like? How can we address metabolic concerns without falling into some of the very real, like fat phobia and weight stigma that we are all subjected to in our society? And how do we best provide patient care in an informed way that doesn't avoid what's right in front of us? So if anyone is curious, like where this topic bore about, that is the origin story. And we'll see if hopefully you all leave not feeling as defeated as my friend and colleague. But if you do, I want to know that too, because it means we just need to continue the dialogue and to continue to develop the concept. Next slide, please. So I think first and foremost, it's important to recognize that there is real tension, right? When, as providers, we are seeing markers that suggest compromised metabolic health. We know we need to have this conversation with our patient, but we're worried that if we say or do something wrong, we're actually going to cause iatrogenic harm. And to that, I would say this is a valid concern. I would say upwards of 60 to 70% of the patients that I've cared for at higher levels of care with primary eating disorder, a healthcare provider is involved in the development of their eating disorder. And usually it's these conversations gone awry, or it's these conversations done in a way that wasn't thoughtful or didn't acknowledge the risk of eating disorder behaviors. And there's literature to support my experience. Clinicians are a documented source of weight bias, and weight stigma from healthcare providers has been shown to contribute to development, maintenance, and relapse of eating disorders. So this tension that we're talking about and the fear of having a conversation is valid. And not having the conversation can cause harm too. And I think that's where we're getting stuck, is we know that if we do this wrong, if we're not thoughtful about how it's approached, we can cause harm. But on the other end, not having the conversation isn't okay either. Um, it can delay care. And more importantly, in my mind, it can leave patients to their own devices, right? To self-guided dieting, to looking for resources and information in places where resources and information are really not evidence-based. I'm thinking like social media in particular. So there is risk not just to having the conversation, but to not having it, or to avoiding it. And so what I'm hoping to kind of talk through today is how can we find that middle where we can address the medical risk and protect against harm as it relates to eating disorder. So next slide, please. I think we need to accept as a premise that eating disorder occurs across all body sizes. I think that is often missed, particularly in people who have bigger bodies, or in people for whom we're not necessarily concerned about their body shape or size. We sometimes forget to screen or to consider that an eating disorder might be present. And I think that's really pitfall number one, is when we forget that eating disorder comes in all shapes and sizes. Specifically, our patients in larger bodies who have atypical anorexia nervosa have equivalent rates of bradycardia, equivalent rates of orthostatic instability, really high psychiatric comorbidity, and pretty significant risk of suicide. And I think that's important that we all kind of hold that truth in the back of our minds, that you can't necessarily tell by looking whether or not someone has or is at risk for developing an eating disorder. So having the conversation, asking the questions is very, very important, and understanding that restrictive eating disorders in bigger bodies are as dangerous as restrictive eating disorder in smaller bodies as well. And sometimes I think that atypical anorexia nervosa really kind of turns off our clinical brain, and we forget that there's real medical risk there too. I think it's important to recognize that what I see clinically is that our encounters day to day with patients as we're talking through these issues have great potential to prevent harm. Conversely, they also have great potential to reinforce harm. So I think 18% of patients who present to higher levels of eating disorder care attribute the onset of their disease to anti-obesity messaging, and about 10% specifically cite healthcare as the source of their eating disorder, which is something that's really humbling for me and something that I'm always kind of holding in the back of my mind. Um, I think one of the most common pitfalls is a comment praising weight loss without expressing curiosity or understanding how that came about, often sets into motion a series of events that don't serve patients and that lead to exacerbation of maladaptive eating disorder. I also think sometimes we give haphazard counseling around nutrition. So if the messaging is just eat less or just cut back, that's not particularly helpful or actionable, and it leaves people feeling confused and often kind of seeking additional resources elsewhere. So next slide, please. I think with that kind of background, the first objective here is to really talk about where we see weight stigma and fat phobia in healthcare, what it looks like, so that we can all kind of go eyes wide open into our clinical encounters through the lens of patients living in bigger bodies. Next slide. So this is language and a graph from a study that specifically looked at the prevalence of eating disorder based on BMI. So it's using very clinical language, hence the word obesity, overweight, normal weight, which for the purposes of our conversation, we really want to stay away from with patients. But I think honoring like the parameters that were used in this specific study, they broke people into these groups. And what they found is that the rate of eating disorder was significantly higher among people in bigger bodies relative to people who were, quote, normal BMI. And the odds ratio is pretty compelling, right? Like a 2 to 4.1 odds ratio is quite significant. That's not just a blip on the screen, that's translating into clinically meaningful variability in eating disorder prevalence. And I think, if we look at young adults specifically, about 30% of women, 15% of men who are characterized as obese or overweight by our current parameters report disordered eating disorder behaviors, which in both of those groups, that's about twice as high as it is for normal weight matched peers. So I think it's just important to recognize again that you can't tell by looking when someone is going to be at risk. And so that needs to always be in the back of your mind when you're having conversations about health and body as it relates to size specifically, because the risk is actually greater in people living in bigger bodies. Next slide. I think, you know, atypical anorexia specifically, so restrictive eating disorders, people often don't appreciate the severity of that diagnosis. And I think everyone has an idea of eating disorder that is white, cis, and female, right? So hence the images kind of in the background here. I think this is when you ask someone who has an eating disorder or what does an eating disorder look like, this is the imaging that's really been propagated for decades and decades and decades. And honestly, I would say since, eating disorder was first identified as a disease, it was a white cis woman's disease. And what we've learned over the past certainly last few decades is that that couldn't be further from the truth. So atypical anorexia nervosa accounts for, I would say, as high as 80 to 85% of patients who come to eating disorder treatment programs. Certainly that was my experience clinically when I was at the inpatient level of care for eating disorder. Is the bread and butter really was atypical anorexia nervosa, which is often characterized under that OSFED, so other specified feeding and eating disorder moniker. And again, the clinical presentation is equally as severe. There's no significant difference in bradycardia, orthostatic instability, suicidality, psychiatric comorbidity. These people can be very, very sick, and treatment is often life-saving. The one thing that we do know, the distinction between atypical anorexia nervosa and anorexia nervosa, is that there's actually more psychological distress around body in patients who have atypical anorexia nervosa. So when a patient in a larger body loses weight, I think our instinct often, because of, our day-to-day exposures and lived experience, is to praise weight loss. And that can be quite dangerous. And if you think about the seriousness of atypical anorexia nervosa and how it often presents and is missed, hopefully that can remind all of us that you want to screen before commenting or praising weight loss. And I would argue you really don't want to frame the conversation in weight loss at all. It's more about health, wellness, and nutrition, but that's kind of a little bit later in the conversation. Can we move to next slide, please? I think there's one slide before that. In this slide, like a little map that flies in to talk about how stigma kind of feeds into eating disorder behaviors. And it was looking at a systematic review of about 242 studies specifically designed to explore stigma. And what it demonstrated is that there was a consistent relationship between greater weight stigma that's either experienced, anticipated, or internalized by a patient with more disordered eating cognitions and behaviors. And longitudinal mediation analysis showed that essentially when someone experienced weight stigma, they internalized that weight stigma, and then it led to more eating disorder behaviors down the line. Specifically in this study, what they saw was binge eating with weight cycling, and the weight cycling led to more stigma, which reinforced the stigma further. And you just get caught in this vicious loop because that internalized bias is driving binging and restriction cycles, and that becomes self-reinforced over time. Some qualitative studies have shown that when providers pathologize changes in weight, that can be a direct antecedent to eating disorder behaviors. And qualitative work has shown that provider praise of weight loss specifically, not necessarily metabolic changes, but the number on the scale, that can reinforce restriction and minimization of eating disorder behaviors in larger bodies delays diagnosis and care so that these folks are actually presenting worse than they could have been had someone screened and intervened sooner. So that's another example of how weight stigma can drive eating disorder pathology. So where does weight stigma and weight bias live in healthcare settings? I think we're all bringing our own implicit bias to work with us every day. 87% of doctors show some degree of anti-fat bias in studies that have been completed, and this is comparable to the general population. What this means in terms of clinical behavior based on studies to date is that physicians will spend less time with people in bigger bodies. They will provide less anticipatory guidance or education. And there's just a general report of less respect for patients living in bigger body. The other thing where we can find stigma in healthcare, language and documentation. So terms like obese, fat, and large are often perceived as stigmatizing by patients and families. And our documentation, because of the 21st Century Cures Act, is accessible to patients and families. So it's really no longer adequate to document or keep notes as if it's only going to be reviewed provider or through the clinical lens, because our patients are reading those notes, some of them in a pathological way. I can't tell you how many patients I've had to kind of talk off ledges because while they're at inpatient, they get access to their phone or they have computer time and they log into my chart and they're just like doom scrolling through their medical records, reading some of the language that's used in a way that almost feels self-injurious, and it can be quite detrimental. I think the other thing to be mindful of when we're talking about where we see weight stigma is the clinical environment, which is kind of what you have pictured in front of you here. So skills are often put in really public areas outside of patient rooms. Um, we provide gowns that don't fit. We have chairs that are not size inclusive. We have images on the walls that really idealize a certain body type. And that is sending a message that is going to be internalized on a subconscious level, even if it's not something that we're manifestly aware of in the moment. I think, the single most dangerous practice that I've seen is praising weight loss, for the sake of weight loss and weight loss alone, rather than expressing curiosity about what we're seeing clinically and having a conversation about how the person in front of us got to A to B. So you look great, keep it up is not particularly helpful language, and it can be quite detrimental. So maybe the most dangerous sentence from the standpoint of today's presentation. Next slide. I think this might be another situation where we have an animation. Yeah, there you go. You should get too fancy with your PowerPoint slides and it just comes back and shoot you, get you. So red flags when a higher weight patient loses weight. So the clinical case here, you've got a 14-year-old who comes in for a well visit, previously in the 97th percentile for weight. They've lost 12 kilos over 5 months, so over 25 pounds. And now they're in the 75th percentile. Comments like from the jump, like walking in the door, "Oh, you look amazing. Oh my gosh, you look so great." Doctor takes a look at the chart and says, "Oh, that's fantastic. Like you've made a lot of progress here on weight loss." And there are no questions being asked. So no one is stopping to screen this kiddo and say, "Well, wait a minute, how did this happen?" So if at any point someone had paused to say, tell me about your eating habits, tell me about how you've been nourishing your body, they would have learned that this person was restricting to 800 kilocalories a day. They were engaging in excessive exercise to compensate for going over that caloric goal. They were doing, running 2 hours daily. They hadn't had their period in 3 months. And if you bothered to look at their vitals, you would see that their bradycardic down to 52. So this is a clinical presentation of atypical anorexia nervosa. If you're only evaluating based on the percentile and the percentile alone, meaning you have a kiddo in front of you who's in the 75th percentile, this is going to go way over your head. And so, I think it's important to think through when we see an abrupt change in clinical presentation, how we think about that with curiosity rather than making assumptions. I think it's very, very important always to screen before praise. And I don't think this applies only to weight loss. I think this applies across the board. And I would also argue that we want to get away from praising weight loss for the sake of weight loss alone, because that too is reinforcing this implicit bias and stigma. So rather than saying, great job losing weight, we want to think about how did this person get here? And I think it's always helpful to take a second, even in our adults, young adults and older adults alike, to look at the weight trajectory. We're really good about doing that in peds. And then at 18, it just kind of falls off the cliff. But it can be quite helpful to see the weight trajectory. And someone who has rapidly declined over the course of a year, 6 months, a month, that's a red flag. That should signal to all of us that we need to take a step back and ask some really critical questions about how the person got to where they're at this moment in time. The same thing, and then the third step here is you really want to make sure that you're assessing vitals with as much vigilance as you would assess vitals for someone who is malnourished or appears malnourished, right, in a smaller body. Vitals include not just heart rate, blood pressure, and weight trajectories, but also things like menses in women. So it is very, very important that we're assessing for these things rather than just blindly praising change because we think it's a change that should have happened. I think that's where we're leaning into, again, our own implicit biases here. So the key message, do not let someone in a bigger body, do not let that body create a false sense of reassurance for you that everything is okay. You always want to screen, assess trajectory, and monitor vitals in your patients, especially if you're noticing a change in their trajectory, because most of us have a set point and we stay at that set point. So when you see a shift, that's telling you something. Next slide, please. Objective 2, non-stigmatizing communication that protects against eating disorders. Before we jump into the clinical language, are there any questions, Autumn, or anyone have any pressing slides that they want to go back to before we move on?
Not so far. We did have one comment about menstrual cycles and issues related to is truly a vital sign for women and should be more prioritized.
Yep, absolutely. I could not agree more with that statement. I think that's a question that, sometimes I want to pull my hair out. Nobody bothers to ask. And I think people don't realize that amenorrhea in particular can happen in all body sizes. And in my opinion, has more to do with the rate and the amount of weight loss rather than the number on the scale. And I think the clinical data backs that up as well. So I agree, 110%. All right, moving on to the next slide, please. Before discussing weight, so before initiating any weight-focused counseling, I would impress upon you to ask even a few basic questions about eating disorder risk and vulnerability. There's not right now like a USPTF recommendation to screen universally, but it is my personal opinion that at a well child visit or at a routine follow-up for adults, we all have, 2 minutes and not even 2 minutes to ask very generally about eating habits, about nutrition, about body image in a way that can actually help develop rapport with patients and can allow patients to bring things to our attention that they might not otherwise feel comfortable sharing. So I hope that if you take anything away from this conversation with you, it's to screen, it's to never assume, to assess vulnerability and trajectory. And a question I'm always asking myself, not just when it comes to this specific topic, but in general, like, is what I'm about to say more likely to be helpful or harmful? This is just kind of like an internal gut check. Before I put something out into the universe, I want to make sure that I'm being thoughtful and intentional in the dialogue, that I'm just not checking off boxes. And we can all kind of fall into that habit, especially when we have like busy clinical schedules. So this for me is really kind of a guiding light in all conversations. I would say key considerations. If you have someone in front of you with a history of restrictive eating, binging, purging, compulsive exercise, please don't ignore that. A lot of times patients will tell you, I had an eating disorder, but I'm good now. And we take that at face value. I would say eating disorders, in my opinion, much like substance use disorders, are with you in a sense through the lifetime. That's not to say that you can't achieve recovery or remission, but it's to say that it's something that you have in check and can come back if it's not properly managed, talked about, or discussed. So I'm actually always really hyper vigilant when someone says something like it's very minimizing of their eating disorder history. That really piques my interest. I guess, unfortunately, for the patient, it did not have the intended effect, but that's something I'm always looking for. Any rapid or unexplained changes in intake, weight, or growth trajectory, I'm really going to key into and pay attention to and ask about in a non-judgmental way. I'm always wanting to come from more a curious position. Anyone that's endorsing high body dysfunction or perfectionistic traits, that is going to key me in to maybe ask a little bit more. So sometimes people use really derogatory language to speak about themselves, and the language is often weight-based, and that to me is a sign that there's a real risk for an underlying eating disorder. Uh, my patients who are athletes, right? Even if they don't have frank eating disorder, they're at risk for relative energy deficiencies. And I always want to screen for that. So dancing, wrestling, people in basic training, boot camp, gymnasts, runners, right? Like these patients are at risks, if not for an eating disorder, formally, they're at risk for energy deficiency, and all of these things need to be addressed and screened for. And then I'm also paying attention to what's the messaging from the family or the culture around weight and body. Um, when risk is present, even if I have a metabolic concern, I'm going to focus on stability first and foremost. I'm going to focus on a conversation about nourishment and mental health over a conversation about weight-focused goals. And I would say even when I've made a decision with patient, family, dietitian to bring weight-focused goals to the table, the goal is not the weight. The goal is improving function, quality of life, addressing metabolic concerns. So I try really hard not to frame the language around the number on the scale. And in fact, I have that conversation overtly with patients in bigger bodies, smaller bodies, and quote unquote normal bodies. That it's not about the number, it's about the function always. And I try to frame the conversation in that way. The American Academy of Pediatrics, the American Psychiatric Association, and the American Association of Family Practice all recommend screening for eating disorders before or alongside any weight-related conversations. So even though there's not a recommendation right now for universal screening, there most certainly is a recommendation for screening before you open that can of worms. And I think that's something that we all need to be mindful of. Next slide, please.
Dr. Sita, we did have a comment come in. Why aren't doctor offices reflecting more change with basic stigmatizing things such as placing scales in hallways?
Yeah, I think that's on us as an institution. I think that's something that we all have a role in bringing to the attention of our administrators. That those are conversations that we regularly have at SunCloud. We will walk through our facilities and say, like, what does this look like through the lens of someone living in a bigger body, and is there a way to make it more weight inclusive? And I think the reason it's not happening is because there's not enough advocacy on the ground. In addition to, I think probably not, the thought just isn't there. You know, like we're ordering these things, we're stocking these office, we're placing things where they've always been placed without really thinking about how that might be experienced for the person on the other side. And so hopefully, those of you here today can maybe take that back to your team, to your VP of operations, and have that conversation about what would it look like, what would it cost, are there small changes we can make, are there ways we can shift this that might make people in bigger bodies feel less stigmatized and more included in healthcare. Because if we can't even get people in the door, right, like if the environment is hostile from the jump, how could we possibly be helpful to them? Right? Like we've kind of lost the battle before we've even started. So I think that's a fantastic question. And I would encourage all of us to just continue to champion where we see weight stigma. Let's talk about it and let's see if there's a way we can address it. Any other questions, Autumn?
Nope, not so far.
Okay. So there are some decent primary screening tools, primary care screening tools out there. If you have a patient where you're considering, you know, I need to have a conversation because I'm seeing medical complications that need to be addressed, dyslipidemia, hyperglycemia, insulin sensitivity or insulin resistance, so on and so forth. There are tools that exist and they're not terrible. The SCOFF is pretty quick. And it's got decent sensitivity and specificity. So I think it's 84% sensitive to rule out an eating disorder, 80% specific to make the diagnosis. There's an eating disorder screen for primary care, great sensitivity. 97 to 100%, but not super specific, as low as 40%. So I think, you know, if you are trying to decide between the eating disorder screen for primary care or the screen for disordered eating, I would probably choose the screen for disordered eating. So it's correctly going to classify 90% of eating disorders, and it's got better specificity than the eating disorder screen for primary care. I think more importantly than these tools, which, you know, they're kind of an entree into the conversation. I think formalized screening, absolutely, but the dialogue, the conversation. So, you know, we have patients fill out these questionnaires. Um, and then how many times do we not even look at them? How many times have I gone to my primary care doctor and I'm like, you know, busily filling out the 100 forms that they give me only for the doctor to like, I don't need that, you know? So the screening tools only work if we actually look at the data, which is an important reminder. And that's why I favor personally a more conversational approach. Next slide, please. Or maybe I should say rather than one or the other, both, right? Like a screening tool and a conversation about the diagnoses or the behaviors that you're picking up on the screener. So I am always going to ask about eating patterns before I touch any metabolic concerns that I might have, any weight-related concerns that I might have. I'm going to ask, are there foods you're avoiding? Has anything changed recently in your intake? I'm going to ask people, you know, do you skip meals? Why are you skipping meals? Have you ever used dietary supplements to enhance your body in any way? Why might you do that? Are there other things that you've done to change your weight? And why? What led to those decisions or those behaviors? I also think just a general question about body image can be helpful. How do you feel in your body? Has anyone ever made comments about your weight that bothered you? Do you find yourself thinking about body all the time or more than you would like? And then again, kind of circling back to some previous conversations, I'm going to look at the trajectory always. I want to look at the trend. I love the EMR tool, the graph. I would say most EMRs have it. I love it where you can just see. I'm a visual person. So, I mean, it'll jump right out at you if you take the time, you know, click the button, look at the graph to see. And you're going to be looking for any rapid decline, which can indicate restrictive behaviors, but you're also going to be looking for any rapid increase, right? Which can indicate eating disorder behaviors as well. So for me, it's about looking for change in either direction from the status quo. And then finally, look at the vitals. Before you open your mouth about a change in weight, please look at blood pressure, look at heart rate, look at orthostatic changes, look at menstrual history, like have that data ready so that when you have the conversation, it can be informed by objective clinical data points. If screening is positive, if you're seeing anything in any of these five domains or using any of the screening tools, pause. Just take a second before you start a weight-based conversation and really think, could this be an eating disorder? And if you are suspecting an eating disorder, before pursuing any weight management intervention, you want to get specialists involved, a dietitian, maybe a primary care or a psych with eating disorder expertise, eating disorder therapists. Like you want to bring the people for whom this is bread and butter to the table. I mean, that is collaborative care at its best. And I think that's when we shine in medicine. Next slide, please. When is weight loss appropriate? This could be a conversation in and of itself. I mentioned right when we were starting this kind of pendulum shift over the course of my lifetime, where we went from really aggressively shaming to, oh my gosh, we can't even have this conversation. We're going to cause irrevocable harm. And we totally skipped the center. And that's kind of what this conversation hopefully is about, is how can we find that middle? There are scenarios when weight loss is appropriate, just as there are scenarios in which weight gain is appropriate. However, we have to use caution. We have to be thoughtful, particularly in patients who are still growing or for patients in whom we see there's a risk for eating disorder. And I think the guiding light here in having these conversations is that the conversation should not be framed around weight loss as the goal, right? Weight loss, if anything, or weight gain, if anything, is secondary to health behaviors and function. Energy, sleep, labs, growth patterns. I actually try to use weight neutral or weight inclusive approach when discussing these things. If a weight-related intervention is being considered, it needs to be tied very, very clearly to specific medical indications. No more of this, oh, your BMI is 30, you need to lose weight, because we know that people can be healthy at almost every BMI on the scale. And BMI is not meant to be a metric of individual health. It's meant to be a population-based metric. So if you are going to pursue a weight-related intervention, it needs to be because there are clear medical indications. And that's a conversation that needs to be had with the patient, and it should be conducted in a structured and clinically monitored setting and framed in a way that avoids reinforcing restriction as the goal or kind of amplifying pre-existing body dissatisfaction. So there is structured evidence that says supervised weight management programs decrease eating disorder symptoms. I'm going to say that again. Structured, supervised weight management programs decrease eating disordered symptoms based on the literature that we have available. The caveat there is that they are done in a thoughtful, weight neutral way, size inclusive, and that they're an alternative to self-guided dieting and avoidance of the conversation that increases risk. So it's not to say that you can never have these conversations. In fact, these conversations are best had with healthcare providers, but they need to be done thoughtfully, and they need to focus on medical indications rather than BMI and BMI alone. And I saw a comment pop up on the screen about waist circumference being a better indicator, and I 100%, that is the truth. That's actually a really good point. Autumn, I don't know if you want to share the comment specifically, but I did see it pop up and it goes right.
Yes. It says, I use the waist hip ratio for a better heart health conversation instead of BMI or weight loss, which assists in dietary changes better.
Yeah, I think that's a really good point too, is using other metrics um, rather than relying only on BMI, which again, as I said, was never intended to be a metric for individual care. It was, a population-based metric that kind of totally got turned on its head. And it unfortunately now is so ingrained in our society that it's a little bit hard to walk back. Um, I think that's
Dr.
all.
Sita, we
Yeah.
have one more question in here. Are there any studies starting about how GLP-1s are impacting eating disorders or are creating disordered eating when people are happy with the results they're seeing?
Yeah, so that is that is a presentation in and of itself, and that's something that I'm very curious about myself. I see a role for GLP-1s. in even the work that I do, and it needs to be done very thoughtfully. I think there's data coming out that really pulls us in either direction, and I would say at this point it's too soon to say, where we're going to land. And I think I actually we might. Can we go to the next slide? I think the next slide might be about GLP-1s. Nope. I've got a GLP-1 slide in here somewhere. We'll get to it. But so there is some like conflicting data coming out. And I think much like my annoying answer to most things is it's not either or. Like there's some middle ground. And we as thoughtful, intelligent people have to be able to parse through the nuance and think about when this might be helpful and when it might be harmful. Based on what I know about eating disorder, prescribing a GLP-1 without screening for an eating disorder is a recipe for disaster. I would say before you prescribe a GLP-1, there does need to be screening across the board for eating disorder. I think there is some data coming out actually showing that GLP-1s may be helpful in, or like, I wouldn't say data, but maybe case studies for food addiction. There are some personal testimonials about the role of GLP-1s in management of binge purge eating disorder behaviors. And there are people who have taken the position of saying no, never, ever. So I think we're going to get more data about that in the time to come. And for me, I'm kind of trying to hold that maybe rather than never or always, and really being thoughtful about if I decide to go down this route, I want to do it cautiously and in a very intentional way. And I do think there is a slide on GLP-1, so we'll circle back to that if we have time. Any other questions? We're okay.
So far, that's it.
Okay. So higher risk approaches or languages that cause harm, prescribing strict calorie numbers, I think is really, really problematic, specifically in patients for whom there's an underlying risk for eating disorder. I have seen that go badly more times than I can count. Prescribing specific diets or giving elimination rules without appropriate support or follow-up is also really problematic and can cause harm. Um, Language around weight as the sole proxy for health or representative of someone's well-being is really quite harmful. Using numbers without context. So framing something through the lens of, as I said earlier, you have this BMI, therefore we need to address it because the BMI in and of itself is a medical problem. That is potentially harmful. Context is so, so important. Taking a minute to explain your thinking and why you are concerned to patients, which, I think on our best days is something we do for everyone, and on our worst days is something that gets kind of put on the back burner. But never assume knowledge, right? We don't want to assume that our patients have the same knowledge and awareness that we do. We've been doing this for a long time. We went to a lot of school, like we're there because we're the experts. So explaining and providing context is really critical. And the absence of that is quite harmful. I think labeling things in a very black and white way can be potentially harmful. I think this is like part of a broader discussion when we're talking specifically about food addiction. So I might put a little like asterisk there because there is some literature to show that in food addiction, there are certain food items that can be quite harmful, and we just need to be thoughtful about that. But as a general rule of thumb, want to avoid like that really black and white language around nutrition. Also, words like compliant, non-compliant, throw out the window, like out of your vocabulary. I think that creates like an us versus them mentality, and it really does damage to the doctor-patient relationship. I think safer alternatives or ways to have these conversations, you want to emphasize consistency, adequacy, flexibility, right? So a lot of times eating disorder occurs in the context of either stark rigidity or chaos. Can we find the middle of let's be flexible, let's make sure you're getting adequate nutrition, let's make sure you're getting consistent nutrition. You want to use neutral descriptive language. So you want to talk about like energy levels, metabolic markers, nourishing brain and body. You want to reinforce trust and internal cues when appropriate. So before someone is in that state of like a full-fledged eating disorder or engaging in eating disorder behaviors, we want to teach people to trust their body. When you have someone in front of you who is in the midst of an eating disorder, that advice in and of itself can be harmful because the body cues are turned upside down. So I would say a little asterisk to that too. But as a general rule, the goal is always building a better understanding of what our body is telling us, what our body needs, and how we can meet those needs. And then I also think it's helpful just to ask for permission before you have a conversation with respect to any sensitive topic. Um, I, I think just kind of bulldozing ahead because we have an agenda is certainly not trauma-informed care, but I don't think it's patient-informed either. I think like sharing an observation and then inviting someone to the table is a really useful way to start these conversations, is getting permission first. And the reason I have like the 10 principles of intuitive eating here, and I think there was a little graphic there too, is not because I think that intuitive eating principles cause harm. That's meant to be like a counterbalance. I think intuitive eating principles can actually be quite helpful in having these conversations, um, because they're really, they're developed around rejecting diet mentality for the sake of diet mentality and really evaluating and building our relationship with food and body. And again, I feel like a broken record. I'm going to say this one more time. Praise of weight loss by clinicians is harmful. We don't want to blindly go in and praise weight loss for weight loss sake. If you have someone coming in who's lost a tremendous amount of weight, frame that praise in the context of the clinical indications or why it's helping them medically, rather than, oh, fantastic, you lost 15 kilos in 6 months. That's great. Focus on why medically that might be helpful, whether it's related to blood pressure, cholesterol, glucose, sleep, energy, right? Like that's what we want to reinforce as providers. We don't want to reinforce the number on the scale as the end and the means. Next slide. What is this slide? This is just an example of like, try this, not that. So language swaps that you can make when you're opening a conversation. Please don't frame it as let's talk about your weight. I think the alternative is, would it be okay to talk about health and how you're feeling in your body? Or is it okay to talk about how you're feeling in your body? Is a much more neutral, less stigmatized way to begin the conversation. And I promise you, if you lead with that, you're going to be able to have the conversation that you need to have. It's not going to be lost in the weeds. There's not a lot of euphemism there. People are going to tell you what you need to know, and it tends to be more fruitful, like a more fruitful approach. Again, great job losing weight. Please don't say that. Observe the change, right? Like we don't need to be afraid to talk about what we're seeing clinically, but rather than automatically assuming it's good or bad, let's observe it and let's say, can I ask you about like how this happened? How you've been eating, how you've been feeling? Tell me more. I noticed a change. I think you need to stop eating junk food, cut your calories is something that I hear a lot of patients share with me that was, advice that was given to them at well-child visits. And I think what I have observed personally is there has been a little bit of a shift where instead of saying don't do this, which is just from a like behavioral standpoint, is usually not the way to go, right? Like a cognitive behavioral standpoint. Rather than telling people don't do this, tell them what you want them to do, right? This is like toddler rearing 101. So instead of saying avoid junk food, say let's incorporate this in your diet, or let's incorporate that in your meal plan, or, so focusing on giving people really clear direction on the changes that you want them to make that they can actually act upon, rather than explicitly saying, don't do this or don't do that, or cut your calories. I think that tends to be less productive than telling people what changes you would like to see as it relates to their intake and nutrition. Labs are bad because of your weight. I hope no one here would say that to someone, but I can tell you I've had a lot of conversations where labs are used as a proxy for either everything's good or everything's bad in a way that isn't helpful. I'm actually very cautious about how I talk about labs in my patients with restrictive eating disorders. Often when I tell them their labs are normal, that's internalized as the I'm not sick enough. or it's not that bad. Everybody's freaking out over nothing. I can keep doing this. So I try to be really thoughtful about explaining as I'm talking through the labs what the labs are telling me and what they're not. Um, just saying your labs are great or your labs are bad because of X, Y, and Z is not really clinically useful and can lead to harm. So alternative language here is I'm noticing some changes. There are several ways we can support this. Changes in blood glucose. There are several ways in which we can support this. Let's talk about what that might look like for you. Prescribing exercise to lose weight. I think physical movement is so, so important. And on another day, I might talk about the pitfalls of totally eliminating that. But I think here we just really want to get in the practice of incorporating movement as a way of building cardiovascular health, treating mental health, like building joy, building a sense of mastery rather than exercise for the sake of exercise. Autumn, do I only have until 1 o'clock?
You have until 1:30.
Oh, I have until 1:30.
Yeah.
Okay. All right, fantastic. I was like, I have a lot more slides for you all, so I'll slow down then. I was trying to get through everything in 2 minutes. Um, but instead of saying to someone you should cut calories, you can say, yeah, it's totally normal to think about like your dietary intake. I mean, it's hitting us all in the face all the time, but let's talk about like what nourishing your body looks like in either direction, what it is and what it isn't, rather than giving people a very prescriptive, you need to cut calories. You can only have this much intake in a day. Um, Another kind of helpful framework for having conversations with patients around not just like health and body, but in general is motivational interviewing. I'm sure, we've all talked about this ad nauseum at this point because it is such a useful tool. But to me, I think the most important principle is that it's not about convincing someone to adopt my agenda. When I am employing motivational interviewing, it's not necessarily because I want to get someone to do what I want them to do. It's because I want to understand what's motivating them. What are their values? What is their readiness for change? What does meaningful change look like to them rather than what does it mean for me? Um, I think key skills in motivational interviewing, you want to use open-ended questions. You want to recognize effort, um, not weight change, but effort to improve health. You want to use reflective listening. Reflective listening is a tool when all else fails. I think it's a fantastic fallback. If I find myself a little lost in a conversation, I'm going to reflect back to the patient what I've heard and let them respond to that. And it usually picks things right back up. And then again, summarizing. The 5 A's framework is not technically a motivational interviewing uh, framework, but I would say it's like MI adjacent and it can be really useful. Ask, advise, assess, assist, arrange can guide shared decision making. And when you go through the full step, what they've shown in the literature is that like each step that's incorporated actually increases motivation. So internal motivation for change. Um, so you want to ask permission. You want to assess, and it's interesting to me here on this on this graph that they have advised following ask rather than assess, which I think is maybe a little bit backwards. I would argue that before you give guidance, you want to assess. So ask permission, assess what you're seeing, then provide your clinical advice and assist the patient in acting upon it, coming up with an action plan and arrange follow-up as needed is really like the circle here. But this is a useful tool that I think can help guide these conversations in addition to the overarching principle of don't frame the conversation in terms of weight, frame it in terms of function, metabolic concerns, things like that. Next slide, please. Oh no, I had you on the wrong slide the whole time. Sorry, I've got a split screen. Everyone was probably wondering what I was talking about. Here's the here's the 5 A's framework that I was discussing about, and we'll make sure that if anyone who wants it can have a reference for the slides, especially since I talked through this one without asking to advance. Can we go to the next slide, please?
Dr.
All
Sita, we had a comment come in about the comment reads, I worry the waist to hip measurement will transfer over focus from weight to another number to fixate on. but open to your thoughts.
Yeah, I think when I think about like waist to hip circumference, I think it's a valid point, particularly in people who have like really kind of some cognitive rigidity or obsessionality to their presentation. I think that's exactly right, that if you use the number itself, someone could anchor to it. I think if I understood the comment earlier, it was more internally for using that ratio as a measure of metabolic health. So for us as providers, rather than relying blindly on the BMI, let's think about like the waist to hip ratio when we're trying to decide like are there medical indications for weight loss here. That's how I interpreted that comment earlier. I agree with this comment as well in terms of I don't necessarily want to lead with that or present that as the goal to patients because I think you're exactly right. That just becomes a proxy for BMI and reinforces this like numbers focused approach rather than thinking about the whole self. So thank you. That's a very thoughtful comment. And thank you, Autumn, for bringing it to my attention.
We have one more question. What
Okay.
psychological issues do you see most commonly with people who suffer from eating disorders?
Um, well, that is that's a pretty broad question and it's a valid one. I think it runs the gamut. I would say to oversimplify, probably unifying thread across the board is some sort of trauma. Not always, but I do feel like, the eating disorder is usually at the surface and then there's a mile underneath. And when I start to dig, I really unearth a lot more than I expected to find. So I think trauma is pretty comorbid across the board in eating disorder. I think in folks with restrictive eating disorders, I tend to see more like anxiety, OCD presentations, severe depression, um, maybe some cluster C stuff, so avoidant dependent personality or OCPD type stuff. In binge purge presentations, I often see more affectivity, more cluster B. Honestly, this is anecdotal, not evidence-based, but I feel like I see more bipolar 2 in in that patient population, and that's something that I've wondered about myself is, what's happening there? Is there like a predisposition that's going on, or does this have to do with the diagnostic schema? Um, in binge eating folks, I would say I see a lot of depression, major depressive disorder, a lot of generalized anxiety as well. And I think the other thing that's important here is that most people over the lifetime are not purely going to live in one diagnosis or the other. What I see clinically is people kind of oscillating through the different iterations of eating disorder. And I think what that tells me is that eating disorder is the manifestation of something deeper. That's why I'm seeing people kind of over the lifetime sort of jump from one box to the next. And one of the things that we always say is it's never about the food. Like we all get hung up on the food as the problem, but it's I can say with confidence, I don't think I've ever had a patient present where it's about food and food alone. Like there's always something underneath. And I hope that answers the question in a nutshell. It's actually a pretty big one, and I think one worth having. I think that would be a good topic in and of itself for presentation. All right. Case two, the family in conflict. So in this scenario, you have a 10-year-old who's brought in by mom. Mom says to the pediatrician, they eat too much. I've tried everything. I just can't get them to stop. The kid's pretty withdrawn, tearful to themselves, not really engaged, kind of looking to the side, biting their tongue. What do you do in those moments when you have a parent who's using stigmatized or shaming language directly in front of the child? I think all of us, our initial instinct, or most of us, our initial instinct is to kind of, oh, I don't want to touch that. I don't have time to unpack this. And so we kind of like ignore or let it pass. But I actually think that does more harm than good. So I think in this scenario, what we need to do in front of the child in an age appropriate way is validate this concern without validating the shaming. So I would reframe that for the child and the parent with the child in the room as it sounds like you're worried about her health. And that's important. Let's talk about this in a way that allows Jennifer to be part of the conversation, inviting the child into the dialogue to really share what they're thinking and what they're feeling in the moment. I have had to have separate conversations in the past. I think that's also important to recognize is sometimes the weight stigma is so deep that I'm not going to be able to necessarily navigate it in the moment with the child present fully because it's going to elicit like a strong reaction from the parent. But I do always try to speak to what's in front of me, like the concern of the parent, but also addressing the way in which the language could be harmful to the child and inviting the child into the dialogue. Um, this would also be a huge cue for me to talk to the kiddo about bullying, about body image distress, and about disordered eating behaviors. Like if you have a parent who's using this language in front of the child, odds are there are a lot of behaviors at home that are reinforcing diet culture and stigma that the child has internalized. So this to me would also be a red flag to screen. And I want to model like safe language. I think that's, part of what we do for both our patients and their family is modeling how to have difficult conversations, how to broach challenging topics in a way that is more adaptive and more useful for everyone involved. I think, the teaching point here is probably that parents and family members are often a source of weight stigma. But that's because they're experiencing their own bodies in their own way, and they are in the same society that we're all living in. And so they're internalizing that stigma and that bias from, the time of this until now. We don't want to necessarily stigmatize or ostracize the parents so much as we want to take this as an opportunity for education and for growth. And I think avoidance of the conversation is not going to help anyone, but being willing to have those challenging dialogues again in a non-confrontational way, but in a direct way can be quite helpful to everyone involved. Next slide. Objective 3, integrating risk assessment with eating disorder informed care, which I think is a fancy way of saying, like, let's tie it all together. Let's kind of review some of the key principles that we've gone through today. So we always want to root our conversations in assessing modifiable health factors. We want to anchor the discussion in things other than weight as a proxy. So even though BMI or weight to hip ratio is what might catch our attention as clinicians, we want to make sure that there's secondary data, which I would argue should be the primary data to inform the dialogue that we're having with the patient. Key principles here, we want to avoid suggesting that weight loss is the primary solution or that restriction is the primary solution. We want to really reinforce adequate nutrition, maybe providing some education about the risks of, the bench restrict cycle that so many of our younger patients in particular are experimenting with and how that can impact metabolic health and can lead to unexpected outcomes. We want to collaborate with dietitians with experience in eating disorder for these conversations. Dietitians, they're my best friends. I feel like they just bring so much wisdom and thoughtfulness into the conversation, and they are really well equipped to have these difficult conversations in a non-confrontational way, and I found them to be a great ally. So I would say if you don't have a fantastic eating disorder dietitian in your back pocket, find one because they're very, very useful colleagues and collaborators. Um, I think focus on behaviors and not numbers, right? That's so important here. And I hope that messaging is coming across. You just, rather than telling people, don't do this, give them examples of what you would like them to do and focus on behavior change rather than on an arbitrary number, whether it be calorie prescription or a BMI. And again, use education around blood pressure, education around lipids, educations around liver function and glucose, because these are actionable and they don't require a statement or value judgment on BMI. Next slide, please. Next slide, please. Give me just a second. There we go. Separating weight-centric assumptions from evidence-based risk assessment. So this is, again, just another do this, not that. So lose weight and your blood pressure will improve, not particularly helpful, very shaming and stigmatizing. Alternatively, let's talk about your blood pressure, your lipids, and your blood sugar and the way they interact with each other. Let's talk about the strategies that we can use to address these concerns. We've got medication, we've got mindful movement, we've got nutrition. These can all improve these specific concerns. Um, Joint pain is one that I actually hear a lot. Your joint pain is because of your weight. I think framing instead, like there are lots of different things that can contribute to joint pain. Let's evaluate all of the different things that could be contributing, and let's talk about your best treatment options. Um, Diabetes, you have type 2 diabetes because of your weight. Providing education instead that there are genetic, environmental, and metabolic drivers, and let's focus on getting that glucose in check and kind of improving your overall metabolic health. And then lastly, lab changes. Labs are bad. You need to diet. Please don't say that. Let's talk openly about what we're seeing on the labs, what they tell us clinically, and give people the tools to address them rather than telling them that the only way to fix this problem is through weight loss. Next slide, please. Here's my GLP-1 slide. Um, so I like this picture. I don't remember why I chose it, but I like it. You, you want to screen for eating disorder always before prescribing a GLP-1, and particularly remembering that it's our patients in bigger bodies who are actually at higher risk for eating disorder behaviors. So these are the patients for whom you're going to be most often, although not always, considering GLP-1s. So in that patient population in particular, screening is so important. And you want to monitor really closely if you're going down this road for rapid weight loss and restriction, psychological distress evolving around body and body change. And I think it's very important to frame GLP-1s as a tool, not the tool, if you are in fact going to go down that road. And I have kind of an entirely separate talk on this topic because I just think it's really fascinating. I'm kind of drawn towards these intersections where there's not a perfect answer, where there's a lot of uncertainty or things to be learned. And I think GLP-1s are a really good example of that. With GLP-1s through the lens of someone who specializes in eating disorder, I think you just, you do want to be mindful that you're suppressing appetite. So if you have someone who has struggled with restrictive eating disorders in the past, this may not work so well for them. This may scratch an itch and lead to some problems. So you want to be thoughtful about that. You want to frame the medication again as a tool, and you want to kind of share with people that at this moment in time, like we were discussing previously, there's not adequate data to tell us on the way in which GLP-1s, that interplay of GLP-1s with eating disorder risk specifically. And I think the conversation around GLP-1 needs to be thoughtful as it relates to eating disorder history and eating disorder risk. Next slide. The referral that wasn't. So here is the semaglutide case actually. So you have a 26-year-old with high BMI, type 2 diabetes, and metabolic associated steatotic liver disease, and they're referred for, quote, weight management. This person has a history of binge eating disorder, and that completely got missed. No one took a moment to screen. They started them on semaglutide, and over 4 months, this 26-year-old lost 18 kilos. So pretty significant weight loss. And person is getting a lot of external praise for that weight loss. So there now is introduction of restriction that really amplifies the effects of the medication. They develop amenorrhea and fatigue, A1C improves, and they receive a lot of praise because labs are looking better, numbers are looking better. And again, because their screening wasn't completed before the medication was prescribed, we missed some of the risk here. So this is now someone who's gone from binge eating disorder to atypical anorexia, and the conduit for that transition was the use of a GLP-1. That isn't to say that semaglutide may not have a role in binge eating disorder. It is to say that when we are using semaglutide, um, we need to know if there's an eating disorder there so that we can take proper precautions, so that we can check in, so that we can screen, so that we're going to see the red flags as they present. So there were a lot of missed opportunities here, and adverse outcomes as a result. So again, I hope the takeaway from this case is not never ever. I hope it's let's be thoughtful. If you're going to go down this road, you need to go down this road eyes wide open. You need to screen before you prescribe. And you need to talk openly about the risks. People with binge eating history may oscillate into more restrictive eating disorder. That's something I see very commonly. And so educating patients, letting them know, like, hey, let's talk openly about how you're feeling as this is happening and what changes you're noticing, how it's impacting your body image. Again, it's about that iterative dialogue with patients rather than blindly moving ahead based on a number and a number alone. Next slide. Um, and the title of that slide, the referral that wasn't, that's meant to imply that had we screened, this person would have been referred to people with expertise in eating disorder, and that likely could have avoided significant harm down the road. Which brings me to our current slide, repair after harm. I was actually having a conversation today with a colleague that I feel sometimes that a lot of the therapeutic work that I do is specifically around acknowledging harm that has been done in the medical system without necessarily blaming people for whom I wasn't there, I didn't know what happened, but simply acknowledging that iatrogenic harm is very real and it can be done. And we can also repair that as providers down the road by acknowledging that the harm actually occurred. I think harm related to our conversations around body size is more common than we realize. And acknowledging that can actually be really healing for patients. So again, I believe we talked through this study a little bit earlier, but patients in higher levels of care presenting with eating disorder identify a conversation with a healthcare provider as the impetus to their eating disorder in 10% of cases. Notably, I think too here, 45, almost 46% of the messaging is coming from the schools, 25% coming from the media, 9% coming from family, which I always found interesting that people identified healthcare providers as an impetus for eating disorder behaviors more frequently than they identified family. But I think naming the possibility that conversations in healthcare settings may have contributed to disordered eating can actually be really helpful. And if we do it without defensiveness, it can be healing for our patients. Um, I think validating that weight stigma is real, that the built environment in and of itself is stigmatized, that the language that we use is stigmatized, that there's implicit bias, um, is also very important. Um, I think, you know, shifting the focus to nourishment and stabilization is also very helpful. And we really want to avoid doubling down on prior recommendations that may have contributed to harm. Sometimes we take a defensive posture for our colleagues because we don't want to engage in splitting and we also don't want to undermine like other people's expertise. But I do think it's really important and again, has the potential to be therapeutically healing to acknowledge when harm has been done. Next slide. Okay, next slide. Takeaways, screen, screen, screen. Never assume by looking at someone that they do or do not have an eating disorder until you've asked the questions. Assess metabolic health before you enter into a conversation about weight loss or weight management. Ask permission before you start that dialogue. Anchor in neutral language and focus not on the number itself, but about function and metabolic outcomes. Make sure you include people with expertise in these types of situations and continue to ask the questions over time. Um, Cross-sectional evaluations and conversations are useful, important, they're part of our bread and butter, but that longitudinal assessment is so much more valuable. And so just continuing to ask the dialogue, you screened someone a year ago you weren't seeing anything, still want to ask the questions when you see them again because things can change, they can shift. Next question or next slide. Check your own bias. Harvard has like a pretty cool, I'm sure you've all done like those implicit bias assessments, but Harvard has a pretty cool one specifically for like weight stigma and weight bias. And I do think it's useful for us to kind of check ourselves and see where we fall. It's also kind of fun to do like the tap, tap, tap back and forth. It doesn't take too much time. So if you're curious, you can take the weight IAT at implicit.harvard.edu. I also think, reflective questions for ourselves. Have you ever praised weight loss without asking how it was achieved? Have you ever assumed that someone in a larger body couldn't have an eating disorder because they were in a larger body? Have you ever documented non-compliant in someone's chart because someone didn't follow a weight loss recommendation? Um, I think there's a lot of reason for us to reflect internally on our own bias and to own it, because once we own it, it can really be helpful in terms of how we approach patient care. And lastly, last slide, I think, well, no, last slide might be gone. Last slide was just a list of resources for kind of screening for eating disorders. Um, and so if we send this out, we'll make sure that you have, or if you request the slides, we'll make sure that you have the resources. And then also like there's a reference slide too that could be useful for anyone that wants to learn more. Key takeaways, eating disorders, all shapes and sizes. Atypical anorexia nervosa medically can be equivalent to anorexia nervosa. Language and documentation matter. And we want to recognize that our words can do harm and avoidance does harm also. So we don't want to shy away from these difficult conversations. I think if anyone is equipped to have them, it would be all of us here today. So we want to feel empowered to have those hard dialogues. And also, if we mess up, we mess up. That's okay. Like we're going to learn as we go. And that's where the repair piece is so, so important. Um,
Dr. Sita, we do have one question about the long-term effects of GLP-1 usage. Um, so are GLP-1s not healthy in the long term?
I think we're still kind of sorting that. I mean, if you think about like the trajectory of GLP-1s, even though they've been around in some form since actually, I want to say the earliest iteration was in the 1990s, they really haven't picked up steam until, I mean, there was a little blip around like, I want to say 2020, 2017, 2018, and then 2022, things just kind of took off exponentially. So I think in terms of like long-term effects, we don't yet have a lot of data. I think what we do know is that sporadic use of GLP-1s can be problematic. I think people who use GLP-1s regularly will tell you that they are meant to be used over a long period of time rather than intermittently for a number of reasons. I think, we are beginning to see that there's real benefit to long-term use, so cardiovascular, renal, and mortality benefits. I think we're going to need more time to suss out the harm. So that is a non-specific answer to a question that is still evolving. But I wouldn't necessarily say that long-term use is bad. I would say, if we're going to use a GLP-1, it isn't intended to be used long-term rather than intermittently. I think where there's more data is to suggest that like off on, off on, off on use is actually pretty hard on the body. Other questions?
I think we have gotten them all so far, unless some come in at the last couple of seconds. But really want to thank you, Dr. Sita, for taking your time to share your expertise with us, and really want to thank everyone who attended this presentation. We love offering these. We have more coming up in the fall, which I think Sal is going back to that. So you guys can register for the ones that we have coming up. September 17th, we have a conversation about hormones. October 7th, we have trauma healing through the internal family system. November 18th, we have centering survivor agency and the role of AI. And December 10th, we have poor decisions, which is about that alcohol burnout loop for professional women. So if any of these are of any interest to you, we would love to host you all again. Thank you so much for everyone who attended. We hope you have a great day.
Yeah, thank you all. Thank you for the questions and for your time. I appreciate it.